Are you able to see this screen?
Yes, sir.
So the informed consent is grounded on ethical and legal concept. That is, it is medical ethics that you tell the patient what is going to happen to him and what you are planning to do, and it becomes a statutory requirement also because of the consumer courts and other legal battles that are going on. It is a double thing that you have to think of. One is ethically we are bound to tell the patient what we are going to do, and legally it is expected that you have to tell the patient from all the lawful activity that is going to be done. And patients have the right to understand what is being done to their bodies and also take a decision whether they want to undergo that or not. And uh, this word battery means it's a crime. It is not the cell or the battery that we use for operating a machinery. The common law battery means it's a crime to perform any procedure, even to feel the pulse or palpate the abdomen without the patient consent is considered as a crime. So without valid consent, we can't even do a routine clinical examination of the patient. That is the first common law battery. Then the second is the negligent failure to warn. So you must tell the patient what are all the possible harm that can happen to him and the risk involved in undergoing a particular type of procedure. And failure to obtain the consent, what are all the consequences that you will face? Is a compromise with patient autonomy. It may increase patient safety risk due to incompetent patient clinician communication. It may be considered as negligence. If you have not informed the patient and got his consent, it is considered as negligent on the part of the treating physician, and it is considered as a crime, battery, and it's a breach of contract or other legal claims as long as the law is concerned. So these are the 5 things that you will be doing or you are likely to face if you fail to obtain informed consent. And a robust patient-centered informed consent is a model of sharing decision making. That is, you tell the patient what you are planning, he thinks over that, and then he gives his decision whether he wants to go ahead and accept that treatment modality or not. So it enhances patient safety, improves patient satisfaction, meets ethical and legal duty to the patient, increases staff morale, and reduce legal risk to the healthcare provider and organization, and lastly, ensure compliance with regulatory and accreditation requirements. So from all these angles, a properly informed consent in documented form is very, very important. So informed consent is much more than a signed form, and the anesthesia professional and patient develop the anesthesia plan through discussion of alternatives and risks and benefits of the plan. For example, for a TKR, you suggest that it is best done under spinal anesthesia or epidural anesthesia. And patient says, she's a lady patient, she says, I have undergone cesarean section and the anesthetist poked my back several times and I have developed backache. So I don't want spinal anesthesia, I want only general anesthesia. If they are very adamant and dogmatic about it, you cannot force them to have spinal anesthesia for the surgery, even though it has all the advantages. You can still explain and try to convince them, but if ultimately the patient refuses to have the type of anesthesia, you have to accept the patient's choice and go ahead and give them general anesthesia. So that is where the discussion helps to avoid unnecessary complications. So without telling the patient what you are going to do, you just straight away take the patient to the OT and start preparing for a spinal. The patient may start giving you trouble from that time itself. So it is always better to inform what type of anesthesia you are going to give and what are all the things. For the example, if the patient is going to experience the anesthesia for the first time, you must tell in detail what all the things you will do. If it is you are planning a GA, how you will start the IV line, how you will make them go to sleep, how you will maintain the anesthesia. All these things can be explained and make them to understand and then get their consent. Now coming to the elements of anesthesia consent, first is the competence and decision making capacity of the patient. So the patient must be in a good sound mind to understand the legal authority to consent. They should be over 16 years of age. Till the time they are all considered as pediatric age group. So they must be in a legal age competent to give the competence, and they have they should be adequately informed about the relevant information, the nature and purpose of proposed anesthesia or the anesthesia techniques. What are the risk, benefit, side effects of these anesthesia techniques also should be explained to the patient. What are the alternatives and their risk and benefit and side effects? These are all the disclosures and risks of not receiving the anesthesia care. So all these things should be discussed with the patient. Third is understanding the disclosed information. So first is the patient's ability to make a decision, competence. Second is the onus on the anesthesiologist or the provider to discuss all the pros and cons. The third is the patient should understand the disclosed information and demonstrate that he has understood that. And last is the fourth is the voluntary consent. Patient should not be coerced to accept final anesthesia because you want to make sure that that will be the best method. If he accepts voluntarily, then it is well and good. Otherwise, there is no compulsion or duress should be there. And last is the documentation. Health record contains appropriate documentation evidence of patient's consent for anesthesia. Now, if the patient has received any anxiolysis or analgesia, and the anesthesia professional determines that the patient has a decision-making capacity by considering the medication effects and the patient's demonstration of rational reasoning. So, for example, if a patient comes for a trauma with a polytrauma and he's in a severe pain, and somebody has given him a shot of fentanyl or morphine for pain relief, and you want to take a consent from that, you must first understand whether the patient is in a normal state of mind to understand what you say and then only take the consent. So these are all special situations. So mostly what we described earlier is are all elective situations where you can easily talk to the patient and record all these things. Whereas in situations where there are patients who have been given some analgesic or anxiolytic, or the patient decision making capacity is in a questionable state, then you have to do what is called a mini mental status examination, or sometimes even psychiatric help has to be needed. And once determination has been made, important to document the determination of the patient's decision making capacity. So the first column or the first class of what is required is the decision making capacity can be questioned in these various situations. So if there is an alteration in the mental capacity of the patient, you have to document that. For example, elderly patient with a little bit of Alzheimer's, at times he may be lucid, at times he may be forgetful and amnesic. So in that situation, it has to be documented that his decision-making capacity is like this because of this particular underlying problem. And patients who become incapacitated, they can have a decision making authority transferred to a legal decision maker. So patients who already have a stroke, who cannot verbally communicate, they can hand over the decision making capacities to somebody who they agree as a legal decision maker for them. And this can be, and they can make the informed decisions with regard to the law that is prevalent in that particular state. And the designation continues till the patient's anesthesia care is over, until the patient he himself should withdraw that consent given to the legal representative for him, either orally or by writing. Until then, that legal decision makers suggestions, I mean decisions are valid for all these things. Now coming to the disclosure of information, what are the special situations where you may have to alter that? Anesthesia professional provide the information that is relevant and helpful in making a meaningful. You should not frighten the patient too much. That, for example, there is a 1 in million chance that under spinal anesthesia you may die. You should not start saying that as a first thing. So you must give the relevant and helpful decision-making incision, the information. And informed consent begins with an explanation of patient's decision-making role and continues as interactive process of communication with alternatives. And you must give all the risks and benefits and encourage the patient to ask questions and clarify whatever doubts he has got. So it should be a detailed discussion on that. And if applicable, the goals are set care and the possible recovery concern and post anesthesia period like vomiting, shivering, all these things are to be discussed with the patient. Then the degree of disclosure regarding risk and benefits, this varies by state and local law. That is, this is mainly for the American and European countries where the law differs from the state to state. So this is not mostly applicable to us. It is in our country, it is mostly more or less a uniform law. Many jurisdictions use a reasonable person standard, what is material for reasonable person's decision. The risk could be disclosed as reasonably foreseeable, but does not have to include every possible complications. And the material risks are those that reasonable person would want to be made aware of when making decisions about anesthetic procedure. And they include common risks like which are, for example, post-spinal headache may be a common example after spinal. So that can be told to the patient. But those which cause sometimes neurological damage by injury to the nerve, it's a rare possibility, but that need not be always told as a very common complication. And some jurisdictions use the professional practice standard and what reasonable practitioner would disclose. And special considerations in this are disclosure for unplanned conversion to general anesthesia. For example, you plan for a spinal and there is a failed spinal, or in between the surgery gets prolonged and the spinal starts wearing out and you have to convert that patient from regional to general anesthesia. You have to get a consent for that also in advance, that sometimes you may have to convert it to GA. So they discusses the patient the need for possible conversion. Especially when the patient is conscious on the table, you can tell them that I am going to make you go to sleep, and before you just simply convert it into GA. And the discussion possible modifications give the patient opportunity to discuss what they have or what they feel. So it is always better to discuss about GA also whenever you plan for a regional. Then understanding the disclosed information by the patient, they must be able to demonstrate that they have understood what you have told about them. That depends on the literacy and the cultural and religious beliefs of the patient. So according to that, you have to make sure that what you have told has reached the patient and he is able to understand the things correctly. And formal documentation of informed consent provides evidence that the informed consent process has been completed, and it will help protect the anesthesia professional from legal liability and disciplinary action. So this is a very, very important form to document all this. And what about the timing of anesthesia and informed consent? Sometimes, you know what happens, you go and assess a patient today, and initially the patient is planned for a surgery within 2 days or 3 days, but for some reason, like nowadays, you know, the insurance, especially in elective cases, clearance is not obtained or something happens in the family and the patient gets discharged and goes back and then says he will come and have the surgery after 1 month. At that time, the initial consent that you got, is it valid till the time he comes back and has a surgery at a later date? That is the question. So some facility policies allow informed consent obtained within the specific time period for the procedure. And the process of form, but again, every time you must review the patient and make sure his health status has not changed from what you saw earlier for the when you gave the fitness or the consent, when you got the consent. So it is mandatory on the point of the anesthesia provider to make sure what is the current health status of the patient. If there is a gap between the time of obtaining the informed consent and then the timing of surgery, which is more than sometimes 2 weeks or 3 weeks. So anesthesia professional and patient should engage in informed process of consent again, including signing the document and completing the process if there is a long gap between the first consent obtained and the timing of surgery. Now, what about emergencies and implied consent? Supposing the patient comes with a multiple polytrauma and he requires surgery immediately. So, if the patient is unconscious or is incapable of consenting, then and if the immediate treatment is life-saving, then there is no reason for you to wait to get the consent. So, if the procedure is imminent and outweighs the potential harm for performing the procedure, then you can, if true emergency exit, consent is not required since it is implied that he has to consent for that. So emergency should be documented in the patient's record. You should say why you are taking the patient without getting the formal informed consent and what is the nature of emergency. For example, a pneumothorax, you can't be waiting until the patient gives consent if the patient is unconscious. So you have to go ahead and put a drain and save the patient's life. So you just document what is the emergency and what is the critical state of the patient and go ahead and do that. And when patient status permits, healthcare professional should attempt to get the proper legal decision maker from the or from the close family members, the consent can be obtained. So this is the relaxation given for emergencies. And what is withholding of information during consent? May withholds some receive relevant healthcare information. Some patients may limit the scope of information they wish to receive. For example, if the patient is a very scared patient, he is very scared about the surgery, you don't have to tell every possible complication to him. Otherwise, he may refuse surgery and run away. So, you must understand the mental makeup of the patient and try to make sure that he is comfortable in receiving the information and not getting frightened with the information that you have given. So they may want some information. Patient himself may say, "You whatever you want to do, but do it safely. I don't want to feel any pain. I don't want to be awake." If that is the request, then you need not go on indwelling all the problems that can happen. So the patient has got the right to refuse to hear all the information that you want to give. And in that situation, limits the applicable legal requirement should respect patients' voluntary choices in receiving healthcare information and educating about them. So what are the concerns in some special situation, critical care and emergency, what we saw, then Jehovah's Witness, obstetric patient where it's a category 1 cesarean section, again you have to go ahead and do chronic pain treatment and research work and teaching that has to be documented properly that what you are doing is for research and teaching purposes, that has to be properly documented, and the following guidelines to be followed during informed consent. It should be for specific procedure, whatever surgery or whatever intervention that you are planning, you should make a note of that and give for the consent is for a specific procedure, and it should be given voluntarily by the competent patient. Common, less likely complications should be explained. Risk related to patients' comorbidities also should be explained. This is where the high risk informed consent comes. So patients' comorbidities, if they are very severe, you have to explain that. Adequate time should be given to read and understand the consent form. You should not just say, put your signature here and walk away. And honest answer should be given to patients' questions. Patient should be given the choice to choose from various anesthetic options given. The whole discussion and patient decision for intervention should be precisely documented in patient's vernacular language. This is very, very important. That is why if you see many of the hospitals nowadays have got the consent form both in English and in Tamil. and in North India they put it in their state language. So this vernacular language or the language which the patient understands is very, very important. And patient should sign the form carefully after going through that, and the date and time should be properly written. That is also very important part of the consent taking. Okay, so these are all the points I think that will be helpful to modify your presentation of the answer. Otherwise, most of the points I think Jay Bharti has nicely elaborated.